we train about 16,000 healthcare providers per year in ACLS and PALS. We try and take ACLS and put it into your environment. The ACLS that's designed for the hospital just doesn't work in the dental office. For one thing, you don't have 15 people on your code team. You don't have an anesthesiologist there to intubate. You don't have a cardiologist there to interpret a rhythm. You don't have an internist there to argue with your cardiologist. You don't have a nurse to give the meds. You don't have a phlebotomist to start the IVs. You certainly don't have a PharmD standing there handing you the drugs and another nurse doing your documentation for you. You are a code team of one in your dental office, and you do need to bring some special equipment, some special skills. That's what we attempt to do. We also attempt to do it with a degree of realism that's been unavailable to us in the past, and that's patient simulation. HAL is what we refer to as a high-fidelity patient simulator. He talks.
I feel fine.
Or he doesn't talk if that's necessary. Sometimes he argues with you.
Can't you just take me to the hospital?
And for sure,
I don't like needles.
he has pulses, all four extremities. He has femoral pulses, he has carotid pulse. His lung sounds and heart sounds are very, very similar to a real human being. That means to you that we can make Hal sick and let you see what a sick person looks like, even though you may not often see a sick person. And I'm not going to coach you. You have to evaluate Hal, determine his blood pressure, determine his pulse, and make a decision to treat without an instructor saying there, well, he just stopped breathing, what are you going to do? He stops breathing, you got to notice it, because I'm not going to say anything. What we'd like to do now is to give a simulation, what we call scenario, that we have been doing for the past couple of days with our ACLS course, to give you an idea of what we teach and how we teach it. So if we can have our dental hygienist come in to see Hal. I'd like to welcome Dr. Dina Wrigley, who's acting as our hygienist today. Dina will see the patient first.
Hi, Hal. How are you doing? You ready for your appointment today?
It's like there's an elephant standing on my chest.
Has this happened?
I hurt all over.
Has this ever
Yes.
happened?
I had a heart attack last year.
Have you drank a lot of coffee today? Are you nervous about your
No.
appointment?
No.
All right, let me get the doctor, okay?
Yes.
Doctor. Hal has an elevated heart rate.
Hi, Hal. How you doing? It's Dr. Stanley. Hal? Hal? Okay, guys. Hal went down. Someone call 911. Bring the emergency bag. Let's start CPR right away. Let's get him on some oxygen here.
Does he have a pulse?
He does not have a pulse. Can you pump?
You want me to start CPR?
Yes, please start CPR. I need a defibrillator right away. We're going to get a king tube in. You're doing a great job. Let's just keep pushing some oxygen into
Tear
it.
open package and remove pads. Tear open package and remove pads. Place one pad on bare upper chest.
Good job.
Place one pad on bare upper chest. Do not touch patient. Analyzing rhythm.
Patient.
He's fine.
Do not touch patient. Analyzing rhythm. Do not touch patient. Analyzing rhythm. Start CPR.
Start CPR.
Give 30 compressions.
Keep pushing oxygen.
Then give 2 breaths.
We're going to go for 2 minutes. If you can give me some epi, go ahead and get some lidocaine ready in case we need it. You're doing a great job.
Doc, you want to override? He's a system.
All right, let's override. Let's do a manual.
Entering manual mode.
Keep going
Press
with
button
CPR.
again to confirm. Manual mode. Charging.
Keep going with CPR while it's charging.
Charging. If rhythm is shockable, press shock button to deliver therapy.
Stand back. We're going to shock.
Shocking.
Shock delivered. Start CPR.
Again, please.
Give 30
Push the
compressions.
for me, please.
Then give 2 breaths.
What happened? Can't you just take me to the hospital?
Pulse.
Ow!
All right, let's
Got a
get this
rhythm.
up.
Don't touch me. Don't touch that.
Hi, Hal.
I don't like needles.
You're doing just fine, Hal. We have EMS on the way.
Okay, folks, thank you very much. Let me give a quick review of what happened here. Dr. Fang, usually I just absolutely made a note that I was going to remember and you wouldn't have to remind me. I'd like to talk first about the King tube. The King is a tube that goes into the esophagus. It's not an endotracheal tube, but is a tube that secures the airway against aspiration of stomach contents and can be placed in 8 seconds or less. Recently been adopted by the U.S. military as Foreman. It's being placed on hospital crash carts all across the country. The reason? There's no learning curve. You do it once, you know how to use it, that's all there is to it. We have not had any dentist fail to place them correctly their first time around. So as you can see, we're placing the device.
Isn't that impressive?
One of the criticisms that I've heard about giving conscious sedation is you guys don't start IVs, so if something goes wrong, how do you get the emergency medicine on board? Down at the leg, we have Dr. Stanley, I think it is. I lost it. Lost my card. Dr. Stanley has placed a needle into the bone marrow cavity. He's done so with a drill that allows him to capture vascular access in less time than it takes to start an IV. The medications are then administered through the bone marrow, as you know, the circulatory system beginning at the bone marrow and out into the body. This has become a very acceptable and commonly practiced procedure over the next 3 years. It's a no-brainer for a dentist. You can't miss it. You're used to drills and you're pretty much used to sticking needles into people. So that is an IO, interosseous, the easy IO. Last but not least, you notice that the other Dr. Stanley decided she was going to believe the machine. The machine said asystole, no shock indicated. Did you notice that? That would be the case in 10% of VF. 10% of VF will show so fine that the machine doesn't notice that it's VF and thinks it's asystole and tells you to start CPR. The other Dr. Stanley at the end of the table made a suggestion and suggested maybe we should override and at least try a shock. They then administered, because they did an override on the Pro Model AED and were able to deliver the shock, which, as you saw, was successful in this particular case. So this is what we've been doing for the past 3 days. I think they've done it pretty well. What do you think?